Can you hear me, please? So I hope you can even see the screen as well. That's right. So we should start. Assalamu alaikum. Good evening, everyone. I am Dr. Khaleel. This is one of the series, lecture series arranged by the STSP. This is the lecture about the anatomy of the spine. Today we will discuss about the spine anatomy. Being a pain physicians, we actually must be aware of the spinal anatomy. So the objectives of today's session are the overview of the anatomy of the cervical spine, thoracic spine, lumbar spine, spinal cord and nerves. So when we come to the anatomy, actually now being a pain physician, we divide the anatomy into basic anatomy, fluoroscopic anatomy, and the sonoanatomy. How we become the master in the fluoroscopic anatomy and the sonoanatomy, we must know the basic anatomy. Then we will be able to identify our structure on the fluoroscope as well as the ultrasound. So the vertebral column composed of 7 cervical vertebra, 12 thoracic, 5 lumbar and sacral each, and the 4 coccygeal. There may be 5, there may be 3, but usually we can count as a 4 on the coccygeal when we do the X-ray. So now we come to the cervical spine. The function of each part of the spine is there. The cervical spine actually supports and cushions our head and neck. The movement of the head and neck really take on the cervical spine. The cervical spine contains 7 vertebrae. However, it has 2 special vertebrae, that is the C1 and C2. From C3 to onward, usually the vertebrae have almost the same characteristics. The first vertebra is atlas and the second is the axis. The vertebral foramina are slightly different in shape as compared to thoracic or the lumbar spine, and they are actually triangular. The spinous process in the cervical spine, they are the bifid, except the C7, and the C7 is the longest one. One more unique characteristic in the cervical spine is the transverse processes. They have the foramina, foramina transversorium. They give the passage to the vertebral artery, vein, and sympathetic nerves. This is very important in the cervical spine because when we do the interventions, we must be aware of the location of the vertebral artery as well. This is the picture of the typical cervical vertebra. As we can see here, this is the vertebral body. This is the spinous process, which is the bifid. This is the pedicle, and we can see the transverse foramina and the transverse process. And this is the cervical spine, in which the vertebral bodies are stacked together. However, we can see this is the first 2 vertebrae. They are quite different in shape. So this is the lateral view of the cervical spine, showing the muscle attachment there. So this is very important, and we look the cervical spine from the posterior aspects. We can see there is no disc between the C1 and C2. So the intervertebral disc actually starts between the C2 and the C3. And we see the cervical nerves in the cervical spine. The nerves are actually, they are coming out posteriorly. We see this is between the 2 projections. These projections are the anterior and posterior tubercles. we must know about the anterior and posterior tubercle, because this is very important when we do the extraforaminal injection in the cervical spine, or we actually hit the single nerve root. Because in the sonoanatomy, we actually identify these tubercles and we can identify the nerves. So one more thing here, the cervical in the cervical spines, the nerves actually coming from the above vertebra. Actually, they are numbered from above. We will discuss in the detail slightly later. So in the cervical spine, the vertebral bodies, they are actually not large because they are not weight bearing, because small weight is actually bared as compared to lumbar or the thoracic vertebra. However, the increased range of motion takes priority in the cervical vertebra. Due to this priority of range of motion, however, the neurovascular bundle is more at risk. So as I told earlier, the C1 and C2, they have the unique characteristics. No vertebral body, C1 does not have a vertebral body and the spinous process. Actually, this has the lateral masses which makes joint with the occipital and the C2. This has an anterior arch. The posterior surface of the anterior arch is actually connected with the C2, which is the axis. This is the picture we see here of the C1. This is the C2. As we see, the characteristics of the second cervical vertebra is the odontoid process. We also call it as a tense. So in the cervical spine, next come the intervertebral discs. We will discuss the intervertebral disc in detail at the lumbar level. However, a few things are unique to this intervertebral disc in the cervical spine. As we all know that it has two parts, the annulus and the nucleus pulposus. However, the intervertebral disc grows slowly as compared to the vertebral bodies. They are more thicker anteriorly as compared to posteriorly because of the lordotic curve. If we, in a coronal plane, movement is limited by the uncinate process. The uncinate process is another unique characteristics of the cervical vertebra. This is usually in the dorsolateral position, and it makes a joint among the vertebral bodies. Usually, the disc is herniate. The posterolateral disc herniation is limited due to the position of the location of the uncinate process. And these are supported by the two ligaments, the anterior longitudinal ligament and the posterior longitudinal ligament. So different joints are also involved. They are the facet joint. We also say it as zygoepiphyseal joints, and the unique joints in the cervical spine, they are the atlanto-occipital, atlanto-axial, and the oncovertebral joints. The cervical facet joints, they are unique. They are actually in the sagittal plane as the 45 degree. They are angled superior-medially. This is very important to understand at what angle are the cervical facet joints, the thoracic facet joints, and the lumbar facet joints. Because when we see in the fluoroscope, to enter in the joints, it is very obvious, and to see the joints where to enter, we must know about the angulation and the degree of the facet joints. Next come the thoracic spine. There are 12 thoracic vertebrae. The thoracic spine is the kyphotic in nature. There are some special joints. They are the costovertebral and costotransverse. As clear from the name, first, the costovertebral means the joint is between the rib and the vertebral body, and the costotransverse between the rib and the transverse process of the thoracic vertebra. Here, the sternum is anteriorly, and this forms the thoracic cage. There is a limited movement at the thoracic spine, and actually it protects the thoracic viscera. In the thoracic spine, the spinous process, they are slant inferiorly, because in the lumbar spine, they are actually at the they are placed transversely. However, and the thoracic spine, they are slant inferiorly. So when we go for the epidural, we have to keep in mind this slanting of the thoracic spinous process. The thoracic facets, we see in a two plane. At the coronal plane, they are at 20 degree, and the sagittal plane, they are at the 55 degree. Now we come to the lumbar spine. In the lumbar spine, there are 5 lumbar vertebrae. The lumbar vertebra have the larger body, and there is increased range of motion here. This is the posterior view, and this is the lateral view. We see this is the thoraco-lumbar junction, and then the lumbar spine actually at the sacrum that makes a joint with the ilium to make the sacroiliac joint. So this is very important. As I discussed earlier, we'll talk about the motion segments. The 2 vertebra with intervertebral disc, they make a functional anatomy of the spinal cord. And this is the motion segment. If we see here, this is the superior view, the axial view. If we see from above the vertebral body, the number 1 is actually the pedicle, we see. Number 2, labeled as a transverse process. Number 3 is the superior articular process. And below is the inferior articular process. And number 4 shows actually the notch for the inferior articular process. Number 5 is the spinous process. Number 6 is the lamina. Number 7 is the vertebral foramina. They stack together and make a vertebral canal. And number 8 is the vertebral body. When we see, we have to keep this in mind, and we must know about this anatomy, because when we do the intervention, the fluoroscopy, we actually see the structures like this, and then we see the lateral view. We will come to the lateral view of the lumbar spine. So here, when we come to the lateral view, we actually see the foramina. In a posterior view, it is very difficult to see the foramina because the nerves are passing on the lateral side. If we see a lateral view, then we look the picture like this. This is L3 and L4 vertebra. If we see, we can see the foramina. The number 6 is the foramina. The foramina, here we can see the boundaries which are making this foramina. On the anterior side, it is number 1 and number 7 and the vertebral body below. These 2 vertebral body and the intervertebral disc, they make an anterior boundary of the intervertebral foramina. And then we see the number 8, number 5, this one and this one. They actually make both. These are the pedicle. The roof and the floor of the foramina are formed by the pedicle, and the posterior boundary is formed by the superior articular process. So these 2 pictures are very important from the axial view and from the lateral view. Lumbar facets, they are angled as 50 degree of coronal plane and 90 degree of the sagittal plane. Now, if we look at the vertebral body, these are some exceptions we must know, and we may come across this. The C7 may possess a cervical rib. Thoracic vertebra may be increased in number by addition of the L1 vertebra, which may have a rib sometime. L5 may be incorporated to the sacrum, that we see the sacralization and lumbarization. S1 may remain partially or completely separate from the sacrum, and they may be counted as a 6th lumbar vertebra. Coccyx, which consists of 4 fused vertebrae that may have 3 or 5, however, usually we come across the 4 vertebrae. So this is the intervertebral disc L4, between the L4 L5, which we talk about the intervertebral disc and the spinal canal. We are discussing the lumbar. However, these principles more or less actually apply on the thoracic as well as the cervical spinal cord. The discs have a unique structure. Actually, they are like, if we resemble the tire of a car. If we see the outer surface of the tire head, this is actually the annulus, and we see inside, this is the air in the tire is the nucleus. The nucleus is very rich in water. The annulus is formed by the different circular ring-like structure. The one ring is in clockwise fashion, and the second one is the anti-clockwise fashion. This will make actually made this annulus more strong. We'll see in the next picture, this one. This is the nucleus pulposus inside, and the annulus fibrosus is outside. However, the annulus fibrosus, the nucleus pulposus do not have a blood supply, and the inner surface of the annulus does not even contain the blood supply. The blood supply and diffusion of the nutrients and take out the waste matters from the nucleus pulposus takes through the diffusion. Because of this poor blood supply, as the age increases, the water content decreases, the ischemia occurs, and the strength of the annulus decreases. That may lead to radical tears, and later on we see when we come across these patients and we see it's a disc herniations. So this is seen as because there's a poor blood supply, so the blood is supplied actually by the vertebral end plates, and the diffusion between the nutrients and the waste matter, actually their transportation occurs between the annulus and nucleus through the diffusion. So these are the spinal ligaments when we come across. If we look from here, from the left to the right, this one is the anterior longitudinal ligament. This is the vertebral body, and between them is the intervertebral disc. This is the posterior longitudinal ligament. This is actually anterior to the epidural space and thecal space. And then this is the ligamentum flaming, which makes the posterior boundary. And then this is the interspinous ligaments between the two spinous process. And this is the outer ligaments, which we call as a supraspinous ligament. Now we come to the anatomy of the spinal cord. The spinal cord is a part of the CNS. Anatomically, we consider it extends from C1 to L1 in adults. It contains the 31 pair of nerves. They are the 8 cervical, 12 thoracic, 5 lumbar and sacral each, and 1 coccygeal. When we number these spinal nerves, the first spinal nerve actually comes above the C1. It means between the C1 and the occiput. So we number them. They are above. Likewise, for example, if we say it is a C3 nerve, it means the C3 nerves is actually between C2 and C3. It is coming above from the C3 vertebra. So the C7 comes between C6 and C7, and C8 is between C7 and C8. The T1 actually comes below the T1. So from the thoracic, the nerves are counted below the vertebra, and this carries on till the lumbar vertebra. However, the spinal cord ends at L1. From here, then we see comes the cauda equina, and then the filum terminale that actually anchor the spinal cord. And we see here as the dorsal root ganglia as well. I will talk about it a bit later. So, as the spinal cord ends at L1 and maybe in the children at L2, however, these nerves has to supply lower part of the lower limbs and lower part of the body. So, as a rule of thumb, usually these nerves have to travel at least approximately 3 vertebrae to come out from the foramina at the corresponding vertebral level. So this is the spinal nerve. As we see, the dorsal root is coming, and then this is the ventral root. The dorsal root, there is a projection, I mean swelling, swollen part of the dorsal root. This is the DRG, dorsal root ganglia. This dorsal root ganglia contains the sensory body, and this is very important structure to understand being a pain physicians, because we actually do the neuromodulation or a lot of procedure encountering the dorsal root ganglion. This dorsal root ganglion, this is usually subpedicular in position, I mean just below the pedicle, but it may be the medial to the pedicle and extra and to the lateral side of the pedicle. When these join, they make the spinal nerve. Now this is the mixed spinal nerve. And, we are encountering the motor part as well as the sensory part. So to block only the sensory part, we have to be careful to proximal to this. And then the sympathetic nervous system comes here as a gray ramus and the white ramus. So this is a structural diagram of the spinal nerves. If we see, this is the pedicle, this is the pedicle. And between the pedicle, this is the L3 vertebra, this is L4 vertebra, this is the pedicle of the L3, this is pedicle of the L4. When the nerves come out, they actually take the dural sleeve as well. So while we are doing transformational injections, we are the epidural injections. If we our needles goes too in, so we can encounter the dural sleeve and then maybe subdural injections. So we must keep in mind these structures while we are doing the interventions. And this is the exiting nerve root. As the nerves, like this is L4, L5, L4 nerve is coming out from the foramina. This is the exiting nerve root. When now the L5 nerve root has to come, the next turn is the L5 nerve root. So L5 nerve roots, as the L4 is coming out, the L5 nerve root is being lateral because it takes the position that it has to go out below the from the L5 foramina. So this is called, at this level, this is the exiting nerve root of L4, and at the same time, this is the traversing nerve root of the L5 because now it is coming in position, it is being lateralized in the spinal cord, and it has to come out from the this foramina of L5. So as I was talking about between the exiting nerve root and the traversing nerve roots, this is the same diagram. This is the L4 vertebra, L5 vertebra. This is we have two approaches actually to intervene. Then that is actually the safe triangle and the Campion's triangle. In the safe triangle, our approach is the subpedicular. We are below the pedicle. However, in the while we are doing this injection, why we are concerned with the safe triangle as the Campion triangle. In the safe triangle, the blood supply of the spinal cord actually in the lumbar region, we come across the artery of the Adam cavex. And we are actually worried that our injection, our particulates may go into the arteries here and they may cause the ischemia. So we are fear of that. However, each approach has its pros and cons and complication. So if we approach below the pedicle, this is the subpedicular approach. However, if we approach between the L4 and 5 vertebrae at the disc level above the pedicle, now we are hitting actually the L5 traversing nerve root. It is more evident in the next picture. So this is actually the Campion's triangle. This is the traversing nerve root. And if we hit here, we are actually hitting the exiting nerve root. If we hit here, we are actually hitting the traversing nerve root. So this is the schematic diagram of the traversing nerve root. So being a pain physician, we must be aware of this basic anatomy because if we are not aware of the anatomy, then we may damage the structure. Actually, we are going for the benefit of the patient, and if patients, damage the neural structure or the vascular structure, this may cause the ischemia as well as the paraplegia. As it is said, because the eyes don't see, but the mind doesn't know. Thank you. So any question, please?
जी अस्सलाम वालेकुम खलील भाई, क्या हाल चाल है? डॉक्टर काशी बोल रहा हूँ।
वालेकुम सलाम जी काशी साहब, कैसे हैं आप? ठीक हैं?
अल्लाह का शुक्र। अच्छा, ये थोड़ा सा रिवर्सिंग, थैंक यू, ये रिवर्सिंग नर्व रूट के हवाले से थोड़ा सा जरा दोबारा एक्सप्लेन कर दीजिएगा कि वो क्या।
So please, as the nerves are coming out, because the you can see the picture on the screen. Am I right?
जी जी बिल्कुल।
This is the L4 nerve root that is coming between the L4, L5 and below the L4 pedicle. This is the exiting nerve root because it's taking exit from here. When we come to the now from the below, this is the L5 pedicle. This nerve root has to come below the L5 pedicle. However, when this L4 was coming out, the L5 was in lineup to come out. Before it is becoming exiting nerve root at this level, it is a traversing nerve root. Why it is important? Because when the discs, when there is a herniation of disc, this may be central, this may be paracentral, this may be at the level of the foramina, this may be at the level of the extra foramina. Now, this is very important. While if it may be the disc between L4 and 5, and we are thinking that maybe it is actually compressing the L4, but it may not be. It may be actually compressing the traversing nerve root of L5. So we have to be know about the sign and symptom, and it may be L4 and L5 or L3 and L4 may be hitting, may be compressing the lower nerve. That is actually the traversing of the L5. Are you clear, Kashif?
जी काफी हद तक.
It may not completely. So let me tell you.
Okay.
Okay, that's it. That's it. So any comments from the seniors?
Khaleel, it's Dr. Ateeq here. I think very practical talk. Thank you very much. But just as the Kashif has asked, what's the difference between the traversing nerve roots and exiting? So what's the practical implication for knowing this aspect of the anatomy? Can you elaborate that, please?
Yeah, that's right, sir. So actually the clinical implication, what I feel is that if this is L4, for example, the L3 and L4 disc is protruding, is herniated, and it is not actually go beyond the foraminal level. It is actually central level. So although we are seeing on the MRI that it is between L3 and L4, however, it is not actually compressing the L4 nerve root. It may be compressing the traversing nerve root, which is actually the L5 nerve root.
Thank you very much, Dr. Khaleel.
Thank you, sir.
I think there are no more questions or comments. So can we close the session then, please?
One is the question, sir, I just got in the inbox, that how we see the facet, how we see the facet joints on the fluoroscope. Although we are not talking about the fluoroscopic anatomy, but still, when we see the facets, actually, we have to first go on a posterior anterior view. We take a shoot from the posterior, the patient is prone, and then we actually square the vertebra. Then on the side, which we are interested, we have to incline, we have to make an angle to see the facet around 15 to 20, or it may be 25. Ji, Dr. Ateeq, please.
I think, Dr. Khaleel, there are no more questions or comments. Should we close the session then?
That's great. That's great, sir.
Thank you very much. Thank you.
Thank you. Thank you, sir.
Thank you very much, Khaleel bhai.
Thank you, Kaishab. Thank you. Nice to see you here once again.
Walaikum Assalam.
Ji, Dr. Asif, please.
Ji sir, thank you.
Oh, thank you. Thank you.